You're listening to Medscape's In-Discussion series on metabolic dysfunction-associated steatotic liver disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Drs VanWagner, Associate Professor of Internal Medicine at UT Southwestern Medical Center and Director of Digestive and Liver Diseases Clinical Research and the Internal Medicine Clinical Scientist Training Program. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers.
Hello, I am Dr. Drs VanWagner, and I want to welcome you to Medscape's In Discussion series on MASLD. I am an associate professor of medicine at the University of Texas Southwestern Medical Center here in Dallas, and I am a board-certified gastroenterologist and transplant hepatologist who focuses on patients with cardiometabolic disease and MASLD. Today, we're going to talk about why MASLD matters in primary care, and I am so lucky to be joined by our guest, Dr. Drs Shubrook. He is a professor of clinical medicine at Touro University, California College of Osteopathic Medicine, where he is the diabetes program director and a board-certified family medicine physician who has special qualifications in diabetes management. He is nationally recognized as a clinician educator whose research and clinical focus really centers on patients with cardiometabolic disease, particularly in MASLD in primary care. So I'm so excited to be joined by him today, and I welcome you all to In Discussion.
I look forward to our conversation.
Excellent. Well, there's been a lot of discussion and a lot of press about MASLD. What is MASLD, and practically speaking, why does the name change matter to us?
Yeah, so as someone who lived in both of those periods, I think it's really important to recognize that the name NAFLD came from really our naivety of what was causing the problem. So I'd find a patient with cirrhosis, not know why. I'd say, well, hey, tell me again, you were not drinking. And that can actually be offensive to patients when we're not really understanding that. The name change to MASLD, metabolic dysfunction associated steatotic liver disease, is actually much more correct mechanistically and actually gives a patient a chance to say, hey, this is not your fault. We're not blaming you for something. This is a serious condition that affects your liver. And so I think while the research is not identical in the two, from a standpoint of a clinician, you're seeing the same condition. The name change can be confusing, but it is a much better name when we're really interfacing with patients and helping them understand what's going on.
I completely agree with you. It was really hard when you're trying to explain to a patient that they have liver disease, and already there's this stigma, right, around what having liver disease means. And I think for me, I know the first thing that patients, when they walk into a liver clinic, they sit down and they say, look, I don't drink. And they want to understand why on earth are they seeing a hepatologist? And I'm sure you see this in primary care every day as well. It really helps, I think, with the framing. So what does it change for clinicians when you're thinking about diagnosing the disease or recognizing the disease presence? How does that change your framework about how you talk to patients about MASLD?
Well, I think first of all, we need to recognize that this is a silent condition and it is something that is serious. And so I think we have to start the conversation. Patients aren't going to come in knowing about this. And often many people are found incidentally. And so we actually have to say, I see this. Okay, this is important. I'm going to understand what's causing this, and I'm going to be able to help you. And I think often we look to problem solve. We're not always looking for silent conditions that fly under the radar. So I think, first of all, we have to tell patients, we're going to look for this. And number two, the tests sometimes don't show the severity. So I actually have to sometimes do some special tests. But we can do a lot of those things in primary care. So we at least can triage people to a low risk or a high risk category.
How often is MASLD actually being recognized in primary care? Are we still missing a lot of cases?
Yeah, boy, we are. I think you could almost ask any primary care clinician, have you ever seen someone that had cirrhosis and you didn't know why, right? So I think that should tell you that that's someone that was missed through the entire screening and diagnosis gamut. And we know that that's true for more than half of people who present with MASLD. They find out when they have cirrhosis. More than a third of the world's population has MASLD, and more than 2/3 of people with diabetes have it. And those are conservative numbers. This is very common. And so because it's silent and it's common, we have to have some strategies to be looking for this, because otherwise we're going to find people too late.
You're walking into clinic tomorrow morning. Who do you need to be thinking about having MASLD?
Yeah. So I think, first of all, because we have a population where the great majority of US adults are either overweight or obese, probably most patients, quite honestly. I think the patients who are at highest risk are those who have other metabolic diseases, such as metabolic syndrome, type 2 diabetes, medically complicated obesity. Those are the people at highest risk. I also would say that we also, while alcohol consumption has gone down in the US, it is a conflicting factor because you can have metabolic and alcoholic liver disease that look the same. And so I think any of those patients, medically complicated obesity, metabolic syndrome, type 2 diabetes, those are automatic people we should be screening. And then if you happen to find someone incidentally on a imaging test or elevated transaminases, which are not the best methods, but if you find it, those are people you should also check.
Such important points. And I know you and I, before we started talking today, we were mentioning that really hot off the press, you were involved in this, that this great pathway just came out by the American Gastroenterology Association, or the AGA, trying to frame and help practitioners in primary care, but also other specialty clinics like endocrinology, cardiology, and of course my own practice in gastroenterology, try to think of a framework about how do you risk stratify patients, and how do you think about this patient population? So can you talk to me just a little bit about what your experience was on that panel, and what did the panel find?
Yeah, so I think this is the second iteration of the clinical care pathway by AGA. We gained from the experience we learned since 2021. So these are relatively new things. And essentially, having some directions for both primary care and liver focused practices was really helpful for us because, one, we had all these experts together talking about what is best practice and what is actionable, right? Because we need both. And so what we settled out on, and again after lots of discussion, is everybody who's at risk should be screened first with a FIB4. It's cheap. It can help you to sort out who's going to be at higher risk, and it can be done in primary care without additional costs. Now, there are some nuances to FIB4. It is not perfect, and it would not be used in a subspecialty space because there's better tools. But in a screening of an at-risk population, the FIB4 is a great place to start. FIB4 is half of the screening if the FIB4 is abnormal. Then you need to look at some kind of elastography or stiffness of the liver. FibroScan is one of the tests that can be used, but there are some blood biomarkers such as ELF, and that also can be done in primary care. And just as a personal note, when I actually do this in my practice, my referrals to hepatology and gastroenterology went way down, but every person I sent needed to see that hepatologist. They had things that they could do. And so I think that's what I want people to take from it. This is something that can really make your referrals much more effective and get patients where they need to go.
I can give you an amen for that one. I really appreciate that. I wish I could see every single patient with MASLD. Unfortunately, as I'm sure you know, trying to refer to specialty clinics, it's like a 6-month wait getting in because there's so many patients. And we really are trying to focus on the patients who really need to be linked to specialty care. Who is that population? What is FIB4 and what are we trying to identify, and why do they need referral?
Yeah, so because we know that like just imaging, like an ultrasound of the liver and transaminases are not great tests to risk stratify, the FIB4 takes it a little bit further. It takes age, AST, ALT, and platelets. If I remember correctly, this was actually developed for hepatitis C originally.
It
Yeah,
was.
yeah. So now when applied to this at-risk population, and it's meant to be at the high-risk population, it actually can tell you a little bit more about that person's risk of level of fibrosis, meaning that if your FIB4 is above 1.3, you're at much higher risk of being F2 or higher. And for those that don't know, fibrosis goes from 0 to 4. Unlike what we had in the past, F2, F3, we actually have FDA approved treatments. And so we actually could do something about it. And so we want to try to prevent people from progressing. And just for the primary care clinicians, in the general population, progression can be one stage every 7 years, but it could be faster in people at higher risk, which means if we're seeing people later, we've missed more than a decade of abnormalities, which is why, again, calling out the necessity of doing that FIB4. And just one nuance, FIB4 has age in it. So in a younger population, less than 35, it may miss people. And in a population above 65, it may overcall. So in the guidelines, we use a 2.0 FIB4 cutoff. for those 65 and above so we don't over-diagnose.
That's a really, really important point. Age is such a driver. I mean, as with most diseases, right? We see this with cardiovascular risk and incident diabetes and chronic kidney disease. Age drives risk. Why can so many MASLD patients stay in primary care practices? And actually, why is primary care the best place for them to be? Why don't they want to come to my clinic?
Well, they may want to come to your clinic, but I would actually say that I love that question. And there's two parts to that, right? So one part is the number one cause of death in people with MASLD and at-risk MASH is cardiovascular disease. The number two cause of death is non-liver cancer. So there are really bad liver outcomes, such as hepatocellular cancer and cirrhosis. But the primary care clinician does not let go of responsibility of doing the one and number two things that actually kill people with MASLD. So we have to say, one, we can do the screening. Two, we have treatments that we could use. And three, because of that cardiovascular risk and non-liver cancer risk, we're going to be doing all the things we should be doing with patients with other metabolic diseases, reducing cardiovascular risk, helping them with weight loss, getting them on medicines that improve their cardiovascular chances. And so I think we have to continue to work with those patients because their hepatologist, more often than not, is really going to be focused on those liver outcomes. And so we don't want to say, oh, we don't worry about anything else. You actually have to double down. I'm going to work harder on weight loss. I'm going to make sure you're on your statin. I'm going to make sure you have drugs that might give you benefit or have been shown to give you benefit for cardiovascular risk as well as liver risk.
Yeah, I could not agree with you more. I'm going to dovetail on one thing that you said because I feel like I get this question every time I'm giving a lecture to primary care providers. You mentioned the drugs and the drugs that we have. You mentioned statins, other things. Do we have to be concerned about using any of those medications in this patient population? Like from a primary care standpoint, do we need gastroenterology and hepatology to bless the use of some of these medications that you're routinely using in practice in a MASLD patient?
Well, I'll certainly give you my opinion. I feel like because cardiovascular risk is the driver, we should be doing all the things we can to do cardiovascular benefit for our patients. For me, the cutoff is when someone has cirrhosis. When someone has cirrhosis, I want to have a partnership to say, what are the medications that are going to have the risk benefit profile that are better? But short of cirrhosis, so stage F0 to F3, I should be doing everything I can to prevent that patient from going to cirrhosis and the complications associated with it, such as cardiovascular disease.
I could not agree with you more. A little bit of a leading question for sure. But yes, please, please, please continue to do all the amazing things that you're all doing and prescribing all the guideline recommended therapies that are out there because they're actually very beneficial, at least in the epidemiologic studies that we have in this population. One of the things that you mentioned earlier, Jay, that I also wanted to touch on just a little bit, you mentioned that ALT and AST, right? I mean, we're routinely getting comprehensive chemistry panels every 1 to 2 years in patients. We're monitoring that over time. How much can we rely on ALT or AST? And is it helpful or when is it helpful? And how do you tend to use those markers?
Like any blood test, we have these normal values, right? And those normal values are often these bell-shaped curves based on population standards. And so those levels may not be the best levels to use when you're considering liver disease. So often we know that people can be at risk for metabolic liver disease with transaminases in the 20s, right? Which is well within, or the upper 20s when they're well within the normal range. So I wouldn't use that as my way to screen. But if I happen to see they're elevated, I'm certainly going to take a moment and say, wait, do I understand why they're elevated? And I'll just tell you, I've been guilty, in the diabetes space, like everybody's got elevated transaminases. And I can't just say, oh, that's just something you see. I think I really have to look at that carefully. And I do, I personally watch the ALT versus the AST, but I think that's not the best strategy is to actually put it in a bigger context. And I think many people, and I did not either, by the way, order CBC regularly. Part of the magic of that FIB4 is that you actually have the platelets as a measure of liver health. Let's incorporate that. And even platelets within the normal range can show up as a risk. And so I think if you haven't done it, please go out there and you either put a dot phrase in your EHR, practice it with MedCalc, or AGA actually has an app that walks you through all of the stages of evaluation and treatment. Put some numbers in and start to see, you'll notice the patterns. And for me, that platelet count is really an important factor, more so than transaminases by themselves, because often transaminases that are quite high have a different cause, right? I should be looking at
Yeah.
hepatitis or other things. So the short answer is that's not the best tool.
I couldn't agree with you more. And I also want to just comment on something that you said that I think was really important. Liver chemistries that are substantially elevated, particularly when they get greater than 150 or 200, most of the time that's not MASLD. It could be MASLD, but it's MASLD plus something else. And because this disease is so prevalent, people can have MASLD and viral hepatitis. They can have MASLD and autoimmune liver disease, right? And I see this in my liver practices all the time. Most of the time, you and your colleagues are great about sending people with high liver chemistries. Nobody wants those people just sitting in their clinics. And so those people seem to be the easy ones to identify to send for referral. But it's the normal or maybe just above the upper limit of normal patients that maybe sit for long periods of time, or they were high in the past and then they normalized and they were high for years and years and years. And then we get, falsely reassured that, oh, this person's fine now. Their liver chemistries are normal, when in fact, they're worse. They don't have any hepatocytes left to lyse anymore. We can't rely on those liver chemistries. And I couldn't agree with you more. So when you're talking to patients, what is your approach to explaining this disease and sort of talking about what they need to be thinking about? Take me through a typical encounter that you might have with one of your patients in whom you're discussing MASLD.
Yeah. So I think, again, I have a diabetes focused practice, which makes it a little bit unique. But many of my patients with prediabetes or type 2 diabetes or those who have medically complicated obesity, I say, insulin resistance has effects all over your body. We know insulin resistance can affect your pancreas. It can affect your glucose. It can affect your brain. Well, it also affects your liver. It's a little bit simplistic to say that, but basically the short version is that insulin resistance drives abnormal fat deposition, and fat deposition can be inflammatory. And so this insulin resistance could be causing inflammation in your liver, and inflammation in your liver can lead to stiffness or kind of scarring of your liver, which could lead to cirrhosis and other things. And so the good news for me, I guess, is that when I tell patients that insulin resistance can affect their liver, people actually usually wake up. Well, no, I can't have that affect my liver. So the good news is that when I say it that way, they suddenly have more interest. I want them to see this as a systemic disease, not an isolated disease. That's why we have to have a systemic approach, because I want to improve insulin resistance for their brain, for their heart, for their pancreas, and for the liver. And I think that makes it a little bit easier for patients to say, oh, I've got to do all of this to help all of my organs. And we might be measuring each organ individually by its effect. But the fact is I need to do all of these things, keep me healthy, including my liver.
That's such a great framing. I'm going to borrow that if that's okay.
You can have it. Yeah.
As I talk to my patients as well. It's great. I appreciate all of your insights and the way that you've really framed this disease for us. I think in the last minute here, I'd love to hear, what is one message that you hope that PCPs take away from this episode?
Yeah. So I think, first of all, primary care are the expert of chronic disease management, screening, and disease prevention. So this falls very well within the norms of our practice. And just like any other chronic disease, if we can find it early, especially when it's asymptomatic, we have things we can do about it. And we can change not only that person's liver health, but their overall health. And so while it is a change in practice, and while I have nothing but respect for all of our primary care colleagues that do a million screenings, right? This is one that's going to be pretty high yield because it's going to be part of the other things we do, right? Cardiovascular risk reduction is something we do for all of our patients. If you screen for this, you have another reason to say why it's important for patients. So join in, use the pathways, and it'll make your practice more effective. You have a way to triage your patients.
Excellent. Well, thank you so much, Jay. I appreciate it so much. And to our listeners, today we've talked to Dr. Jay Shubrook about why MASLD matters in primary care. And I think you've heard loud and clear that it is in your practice. It is common. It's silent. You're already seeing it every single day, even when patients feel well and the labs are normal. The normal labs certainly do not rule out the disease. We talked about ALT and AST, particularly with patients with advanced fibrosis. So those are not screening tools. We need to be thinking about incorporating FIB4 as a routine tool that we're using in practice, and that the majority of the patients actually can and should be managed by primary care practitioners, because you are the front line and the best at managing cardiometabolic risk, and you're already doing it on a regular basis. It is those patients in whom we're worried about, clinically significant fibrosis, those F2, F3s and above, and the cirrhosis patients that need to be linked to specialty care. And again, this is a disease that travels with diabetes, obesity, hypertension, atherosclerotic cardiovascular disease. The leading causes of death, as we talked about, is cardiovascular complications, followed by non-liver related cancers. So all the things that you're already doing in practice are very relevant to this patient population. An incidental finding of fatty liver is really just an opportunity. It's not something to ignore. I speak for the gastroenterology and hepatology community. We are out there to help, and we want to see and co-manage these patients with you. So thank you so much for joining us. This is Dr. Lisa VanWagner for In Discussion.
Thanks for listening to Medscape's In Discussion Metabolic Dysfunction Associated Steatotic Liver Disease podcast series with our host, Dr. Lisa VanWagner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on metabolic dysfunction associated steatotic liver disease.